Okay, so at this time, I think we can go ahead and move to Dr. Borate to talk about her highlights and takeaways from ASCO.
Thank
And
you. I'm going to keep my discussion brief because, as most of you know, ASCO is typically a meeting that is designed to give updates in patients that have solid tumors or solid cancers, whether it be breast, lung, and so on. So I'm going to talk about just two things that I thought were important in ASCO. One is a FLT3 trial. I think Dr. Daver gave a really good background introduction, as well as the landscape of FLT3 inhibitors. I wanted to mention an additional FLT3 inhibitor, which may become a possibility in the future. It's called crenolanib. It's a pan-FLT3 inhibitor, so it acts both against the FLT3 ITD and the FLT3 TKD mutation. And at ASCO, we heard the update on the phase 2 trial, which was presented by Dr. Eunice Wang, and she described about the experience of about 44 patients who got this FLT3 inhibitor crenolanib in addition to intensive chemotherapy that we call 7 and 3. And about a third of these patients were younger than 60. About 2/3 of the patients were younger than 60. The rest were older than 60. And what she described was a composite complete remission, meaning patients who achieved remission after this treatment. The rate was about 86%. More than 90% of the younger patients achieved remission. About 80% of the older patients achieved remission. She also described that the overall survival of these patients has not been reached, meaning they continue to do really well. Their event-free survival as of now is about 40-something months. And she also described that the benefit was seen in patients that went to transplant, as well as those that continued on crenolanib maintenance. The trial allowed patients to be on maintenance for about a year after they completed their therapy, which was the 7 and 3 induction and consolidation. So the reason this is important is, as Dr. Daver described, FLT3 AML is a challenging disease, and we're constantly looking for better agents that we can add to our treatments. And now it looks like we're going to have multiple options. We already have midostaurin, we already give that to patients, and now we have quizartinib, which hopefully will be available. We have gilteritinib, and hopefully a phase 3 trial with crenolanib comparing it to the older FLT3 agent midostaurin is actually ongoing. So in the near future, hopefully we'll have data from that as well. And I think this is all good news for patients that deal with FLT3 AML. The second thing that I wanted to mention is a big study that looked at a concept in AML that actually I think is interesting. And I think this is something the AML field really wants to move forward, and we call it MRD. It used to be called minimal residual disease, and I think everybody objected to the term minimal because we don't think there's anything minimal about having a little bit of leukemia in your body after you've gone through tons of therapy. So the more accurate scientific term is measurable residual disease. And this study was called Pre-Measure, and what it really looked at is how best can we tell if patients who have achieved a remission, they've gone through all their therapy, they've achieved a remission, they're getting ready to go to a stem cell transplant, how best can we tell if they still have small amounts of leukemia in their system? Because we know that, or we think that this will clearly impact how well they will do after transplant. So what Dr. Horrigan from the NIH and his group and other groups that collaborated with him showed that if we can look at the bone marrow of a patient before they're going to go to transplant and measure the mutations that they had in their leukemia, like NPM1, like FLT3, like IDH, using some really sophisticated techniques, and if they do find that they have small levels of leukemia in their bone marrow, then their outcomes after they receive the stem cell transplant, unfortunately, are not as good as patients who have no measurable leukemia in their bone marrow. And the reason this is important is, as AML doctors, if we have that information, we can act on it. We can make sure that before patients go to transplant, they actually have no measurable residual disease, and therefore their transplant outcomes are the best that they possibly can be. If we know that these patients have to go to transplant and they still have disease, then we need to do what Dr. Davar just mentioned is the maintenance, meaning after transplant, you continue them on targeted therapies that then can make sure that they don't relapse after transplant, because patients with measurable residual disease before transplant have higher rates of relapse and unfortunately poorer outcomes. So I think to me, that was a really important study because it showed that we can utilize these technologies in what we call a prospective manner. So this was looked at retrospectively, meaning these patients have already gone through their treatments, they've gone through transplant. But now in the upcoming trials that are ongoing, we can actually look at this before these things happen and maybe change treatment accordingly. So I'll stop there, and I know there's a lot of questions and we can utilize the rest of the time for Q&A. Thank you.
Okay, thank you so much for sharing that information. We do have one question about transplant. This is a question regarding if there's relapse after transplant, what are some of the sort of what's next? What's the recommended steps at that point? I know that's a difficult question.
Go ahead, Dr. Davar. Oh, okay.
Yeah, go ahead. Yeah.
I think that's a very difficult question because we've sort of done all the most aggressive therapies up front. But I do think we now have multiple options. I think we've both been talking about these so-called targeted therapies. And if we know that the patient has a mutation we can target after transplant, then there is still the opportunity to get the patient back in remission. And then the transplanters do a couple of things. They can give additional cells from the donor back to the patient to try to boost the effect of the graft against the leukemia, or they can potentially do a whole nother transplant to get the patient back into a good remission. I think the other huge untapped potential is immunotherapy, and I'll let Dr. Davar talk a little bit about that. That's something he's really an expert in.
Yeah, I mean, I think for now we still have the traditional allo's transplant, which is kind of the best way that we have mature data in trying to cure long-term AML, especially the higher risk groups. But like in lymphoma and ALL, we have now been able to develop, I would say, surrogate immunotherapies that are not as laborious, as expensive, and as intensive or toxic, that seem to be able to replace transplant for certain subsets. So these are CAR T cells in lymphoma and CAR T or bispecific antibodies like blinatumomab in ALL. And our transplant rates, for example, in ALL have gone down dramatically in the last 10 years from maybe 50, 60% to like 10% of the highest risk, where blinatumomab CAR T will not take care of the residual disease. So that is the model that we are aspiring to develop in AML. We are way behind. We don't have anything that we can clearly say will get there, but just given the rate of technology and the emerging other immune components that are being used to generate CAR or even off-the-shelf infusions like NK cells or CAR NK cells, I think that we're starting to see some early signals and ongoing trials of activity with these agents. Some of these data will be presented at the ASH meeting in December this year, and then probably more next year. So I think we're a few years away, but the hope is we could develop off-the-shelf available immune strategies that can be delivered without requiring a fully myeloablative and complete replacement of the stem cell pool. And there may even be other antibody-based approaches that could work here. So we talked a little about the CD47 antibodies like magrolimab, and magrolimab is one, but there are many such CD47 antibodies, lemzoparlimab, TTI, ALX, etc. And then there are also TIM3 antibodies that could also work through targeting leukemic stem cells and enhancing T cell surveillance, and then even vaccines that have not done as well in solid tumors, but may actually make sense in leukemia because the expression of certain antigens is very high in leukemia, making it amenable to potential vaccine-based immunotherapy. So I think we're still early, but we're much better at understanding and also in developing immunotherapies than we were 5-6 years ago. And I think in the next 5 to 10 years, hopefully we'll be able to start using some of these and maybe potentially cautiously replacing transplant for some patients. So that's the goal.
Thank you for that. We have one question that I think this goes back to clinical trials, and I think that this could be a helpful question to talk to with you guys. I work with ECOG Akron as a patient advocate providing input on the design of clinical trials. My sense is that the standard consent forms for trials are daunting for an average patient to comprehend, and we are looking for more accessible and understandable descriptions, quote unquote, executive summaries or other formats that are more inviting to patients. Your thoughts on that, please.
I think if, I can't speak for others, but I think we all feel that if we had our way, the consent form would probably be a couple of pages. However, I think as in many things in the US, there's a legal requirement, I guess, or somebody somewhere has decided that legally there needs to be very detailed disclosures, not only of the side effects of the study medication, which I think is really important because I think patients absolutely need to understand and be informed about what they're signing up for, but also very detailed side effects from what we call standard of care, the potential combination. And there's a lot of legal jargon that these long consent forms have that I think, patient advocates such as yourself know really well. So we try in our consenting process to simplify as best we can. I know that some centers, including ours, create what we call short fact forms. So it's just easy to kind of get a snapshot. Our coordinators create calendars and so on and so forth. But I wish there was a better way to get away from a 40-page consent form. I really do. I'm just not sure there is.
Understood.
Sorry, I was on mute. Yeah, I totally agree. I almost think in a way that they are so big that they become really uninformed consents, because I know very few patients who can actually read them. If it were a 1 or 2 page document that actually summarized the important things and people can actually read them. But a lot of this is not really in the hand, unfortunately, like a lot of medicine nowadays, in the hand of clinicians and clinical investigators. A lot of this ends up with sponsor language and institutional template language and risk management language, and we don't like it, but it's just the reality of the way things are. I mean, that being said, for most big centers, Ohio, MD Anderson, others, our research coordinators as well as PIs are very good at boiling it all down to a nutshell and really telling you the key things. And that's what I really tell patients to look at. I mean, if you look at a consent for a drug, you're going to see like 100 side effects, but in reality, what patients should care about is what are the ones that happen, relatively common, more than 5%, more than 10%, and not what is the thing that happened in 1 out of 1,000 patients, because that will be listed in the consent, but it's not really something you should be worried about. So, your treating physicians and research nurses should be able to really tell you these are the 5 or 6 things we really expect happen with this frequency, and we're going to look out for. The rest of it may happen 1 in 100, 1 in 1,000, but you don't need to worry so much about it at this point.
Okay, and the person who commented with that, or who came in with that question, is Steve. And Dr. Borate, he was responding to your answer and he said, I understand that. How about a 2-page summary or introduction before the standard form so they could understand it better?
I think that's a great suggestion. And I think, again, it boils down to the institution and what is allowed and what is considered okay. I do know, especially when we translate big consent forms into different languages, we actually do have a 2-page short summary form that we use because otherwise it becomes prohibitive to do that. I'm not sure if that would be something that we could really use everywhere. So especially in the big cooperative groups, as you were referring to, Steve. But I think that's a great point. And honestly, we need to hear more from patients like yourself, because I think patient advocacy goes a long way, because in the end, it's the patients who are signing up for these trials. They're the ones consenting. They're the ones taking the medicine. So I think this is very much very important. And if you could continue to drive this forward, I think we all are 100% in agreement and support.
Thank you. And thank you, Steve, for the work you're doing on that as well. There's a couple of questions about MRD testing. What are the best ways to measure MRD what is it, flow cytometry or some other process? And then also along with that, when and how often should MRD testing be performed?
I think these are great questions, and this is something the field is very actively looking at. So the two big methods, as you mentioned, one is flow cytometry, and the other one is what we called mutational MRD, meaning you look at the mutations from the AML sample at diagnosis, and then you follow them during the treatment as the patient goes through the treatment. And I think there's pros and cons to both methods. There's different sensitivities to both methods, meaning how low can they go? Can they detect one leukemia cell among 1,000, among 10,000, among 1,000,000? Unfortunately, as of now, there is no what we call standardization, meaning there is no test that I can send a patient sample to the lab and get the same exact answer. There's a lot of work being done to standardize the measurement of MRD so that we can say, yes, if I send a sample for this test, that's exactly the same thing that I'm measuring in every leukemia sample I send this test for. In the meantime, we all have different tests that we use. Many of us follow the mutations because we know that the leukemia had that in the beginning, and that's something, if they go away, we think this is good. If they come back, we know this is not good. And when and how often should it be tested again is fairly controversial and still in development. But I think most of us look at MRD once the patient has achieved remission, whether it's after intensive induction or after aza-venetoclax, for example. We also look at MRD, as I mentioned in that pre-measure study at ASCO, we really want to see what MRD is before transplant because we know that has an impact of how patients do. And then I think we all have different practices on when and how we measure MRD along the way, depending on the patient's leukemia and how we act on it, including enrolling patients on trials that hopefully can what we call erase MRD. So there's active MRD eraser trials ongoing to try to address this.
And just to kind of, add at this point, we don't use MRD routinely for really any significant clinical decision making. It's still very much in the data collection and research gathering phase. I think it will be in the near future, and some MRDs more than others, as Dr. Borate mentioned. For FLT3, for NPM1, for PCRs, for BCR-ABL, and for core binding factors and APL. There's, I'd say, already significant data to use those as regulatory endpoints, treatment endpoints, drug approval endpoints, and so the FDA is already discussing with many of us how to incorporate. But then for some others, there's still a lot of kinks to be worked out. So I think that for a patient, MRD at this point is not beyond saying that we're happy to see it negative, because that usually is associated with good outcomes. It doesn't change our management. If I'm going to transplant somebody, if they're intermediate or high risk, whether they're MRD positive or not, I'm going to transplant them, but I will know that if they're MRD negative, the chance of the transplant being successful is better. So it's good to become negative, but it doesn't change your outcome if you're not. And we don't have any drug today in AML, unlike in ALL, that can make MRD positive negative in a high frequency of patients. That would be the game changer when we have a therapy like blinatumomab in ALL that can make 70-80% MRD negative, which then has a biological impact of improving outcome. Then it'll become really relevant. So for today, it's more for prognosis and research than selecting or designing the therapeutic strategies.
Thank you. I do know that Dr. Davar has to drop off about 2. So Dr. Davar, I just want to say thank you so much for your time today and your expertise. And it was wonderful hearing from you. And we'll continue with some questions. I think Dr. Borate can stay on so we can keep going with some questions. So Dr. Davar, you can drop off whenever you need to go.
All right. Thank you. It's a
again.
pleasure.
I do have a little bit of time sensitivity, so maybe we can take a few more.
Okay, we can take a few more.
See you guys soon.
Thank you, Dr. Davar.
Thanks a lot.
Thanks.
Okay. There was one question that I thought was a good question to ask. Oh, from an AML caregiver who called in on the phone. They were curious to hear about what kind of success rates they're having with CAR NK therapy or CAR natural killer cell therapy?
I think we're all very excited by the promise of CAR NK cells because I think NK cells are what we call part of our innate immune system, meaning we all have them. They all can recognize cancer cells really well and kill them without too many side effects, unlike the CAR T cells, which can have some pretty severe side effects when they're infused. However, the NK CAR trials are very, very early on. So there's promise, but it's very, very early days. So, I think if you have the option of participating in one of them, I think that's great. Whether or not it will be successful, because we're still sort of working out what is the right dose of the NK cells, um, you know, I think that's a little bit of an unknown right now.
Okay. Great. And I think this is a good basic question because we've talked about a lot of the importance of getting an AML specialist or getting under the care of an AML specialist. Not everyone is, close to cancer centers, et cetera. So how does one access AML specialty care if it takes at least a day to travel to get to a specialist? And can care be effectively coordinated between experts and my local physician? If so, how does that work?
I think that is a great question. I know this is a big issue for a lot of folks because I would say majority of the country does not live near a big, large AML center. And the reality is most AML patients don't get treated at such centers just because it's impossible to drive back and forth several hours a day to get that treatment. What we recommend is, at least in the beginning, get an opinion from somebody who works at such a center. And typically, so for example, if a patient comes to me and they live about 2 hours away, I will tell them the different options we have. I will tell them, what they can expect with different treatments. I'll talk about clinical trials that are specific to the institution, which does involve some travel. And then I'll talk about what treatments they can get, close to home and what they can expect with that. And I think at that point, the patients really decide based on what they can and cannot do. Do they want to start treatment at this more larger specialized center, and then after the first month or so then transition back closer to home, which is what we do a lot. We make that first treatment happen where we practice so we can make sure everything's going well and there's a good understanding of the side effects and so on. And then what we call transition of care to a place close by, and then we stay in close communication. Maybe we see the patient every few months. Sometimes the patients will elect to stay on a trial, and there'll be some travel and there'll be some things that can be done close to home and some things that can be done in our institution because of the trial. But I do think it's nice and actually has been shown to be really good for patient care to get that first opinion, have a treatment plan, and then decide, how that treatment needs to be. If it's all locally, then we usually do communicate pretty closely once we've seen the patient and help develop the plan.
Wonderful. Yeah, I think that's such an important question because we forget that not everyone has the access, unfortunately, to the centers. There's a couple of questions, and this will be our last question, about diet. What diet should my son be on? And this is for a pediatric patient. And there's also one about should vitamins be included in the AML treatment protocol? So if you could speak generally to those.
I think these are great questions, and we get a lot of questions like that from our patients who are going through treatment. I will say, there's a lot of studies been done on diets during AML therapy. Do you have to cut out fruits and vegetables? Do you wash everything? Do you not eat uncooked food, and so on and so forth? And I think it's been fairly well established that the so-called diet, we call them neutropenic diets because patients have low counts, do not work. So eliminating fruits and vegetables does not in any way help patients live longer, do better. We obviously want patients to eat meats that are cooked. We don't want them eating raw fish or raw uncooked meat or even unpasteurized dairy. But pretty much anything that you eat in your normal diet is a good thing to have when you're going through AML, because what we really want is for you to eat, and we want you to be able to eat foods from every food group and get as much nutrition as possible. So there is no specific diet that we recommend other than eating a healthy, balanced diet. There's not really a lot to avoid other than the foods that I just mentioned. And then last but not the least, it's interesting, we don't really have any data to show us that incorporating vitamins helps or hurts. And so I tell patients, if they, take a multivitamin, then keep doing that. If they take certain vitamins, there's no harm in continuing that process. But again, there's not a lot of data to show that really enhances therapy or enhances outcomes or their well-being. Again, it's very much up to the patient what they want to do with that. Sometimes our patients stop because it's just too many pills. Vitamin pills are big and they can cause nausea on top of everything. So again, it's very individualized, but no harm in continuing them. But certainly don't feel obligated to start a bunch of vitamins because of the diagnosis and the treatment.
Okay. And I have one last question just for you. I know you come from a long line of women physicians in India, and that's pretty inspiring. And I was just curious about what makes you optimistic about the future in this area of AML.
Well, thank you for that question. I want to say, I think I'm an optimistic person in general. I remember one of my patients, when I tell one of my patients, I don't really think I'm that optimistic. They're like, oh, you're a leukemia doctor. Of course you're optimistic. But with that said, I do think, when I started this field as a fellow, we literally had 4 or 5 treatment options that we offered to our patients, and a lot of them didn't work as well and had a lot of side effects. But now that number has gone up to 10, 15, 20 different options, and I'm not even talking about clinical trials. I'm talking about options that we can just prescribe to patients. We talked about all these mutations that we can target, and I just am so optimistic about the fact that in that decade since I've been doing this, we have doubled and tripled the amount of treatment options we have for patients. And I know that number is just going to continue to get bigger and bigger. And to me, there's nothing more satisfying that makes me love what I do is obviously seeing a patient in remission, but then seeing a patient in remission, after doing different treatments and in doing these treatments at home, where they're not staying in the hospital for long periods of time, especially our older patients. I think that's really important. So overall, I'm optimistic. I think our research is really bearing fruit, and I think it'll continue to do so in the future.
Yes, I agree. And I'm like Dr. Daver mentioned, just the 9 drugs. I mean, when my husband was diagnosed in end of 2017, I think just since then, it's been the 9 drugs, which is really, really quite amazing. So it gives me hope as well. I hope it gives others hope. And I just have a couple of announcements. Our next meeting we have is an AML caregiver chapter meeting, and that will happen actually tomorrow at 2 p.m. We have Dr. Sarah Tinsley will join the AML caregiver chapter to provide valuable guidance on the caregiver's role in managing common AML side effects. And you can register at www.healthtree.org/AML/community/events. And we would like to thank our HealthTree Round Tables for AML sponsors, AbbVie, Servier, and Jazz Pharmaceuticals. And just another special thank you to Dr. Borate and Dr. Daver for joining us today. Thank you for sharing your expertise and knowledge and your time. And we hope everyone enjoyed the event, and we will see you next time. Thank you, everybody. Have a great day.